You gonna start?
Okay.
I think this is working. Yeah, it seems to be working.
So we tried to decide how to divide this up, and the way we decided how to do it is to look at some of the older treatment trials and then have Dr. Duis and Dr. Thibert talk about current treatments in place in their clinics, and Dr. Elizabeth Berry-Kravis at the end will talk about issues of trying to develop outcome measures for trials, some of which you've heard from, and talking about engaging in a trial. So at San Diego Children's, we were involved in a lot of therapeutic trials starting in the early 2000s. The first one was a trial of methylation, which was based upon the concept that if you methylate the antisense area, you're going to increase UBE3A production and perhaps improve patients' abilities. So the first one was done with folate and betaine at a dose of either 6 or 12 milligrams. 57 kids were enrolled, 48 of them completed at 1 year, and there were more males than females. This was a randomized, double-blind, placebo-controlled trial. We did not know who was getting what. The outcome measures that were used were done at baseline and at 1 year into the study, and they looked at growth, exams, EEG, Bayley-3, Vineland Adaptive Scale, and the Preschool Language Scale. And what came out of this was that there was no difference in the Bayley, the Vineland, or the Preschool Language Scale, no difference in exams, the incidence of seizures or worsening of seizures, and there was a statistically significant difference in the questionnaire about being less hypermotoric in the treatment group. There were a lot of lab tests done during this, and labs that were expected to be increased with methylating treatments were increased, but no other lab abnormalities came out of that. So that was followed up by another push to do even more methylating agents at once in an open label trial. There was no double blind there. Everybody got the compound, which was folate, betaine, creatine, and vitamin B12. And the outcome again was measured after 1 year. 65 individuals completed that, and no meaningful difference at 1 year was compared to a historical control of 16 children of the appropriate ages who were evaluated with the same tools as part of the natural history study. The unexpected outcome is that in a methylation assay that was done as part of this, being treated with the pro-methylating agents did not seem to change that. The next trial that was done through our site and several other sites took tons and tons of work and labor and blood, sweat, and tears by Dr. Wen-Han Tan and Dr. Bird, who first of all, to get the FDA to fund this, had to find what dose might be appropriate, and then to do dose ranging studies and so forth. So that was the first part of that. But then what was developed was a double-blind randomized placebo-controlled trial at 7 sites. The idea behind this was that there was some early basic science data that had shown that levodopa-treated mice with an Angelman mouse model had improved motor performance, and it was found to improve what's called long-term potentiation, which is a measure of learning in an animal model when those mice were given levodopa. So 67 began the therapy, 55 of them completed, and the number of withdrawals from the placebo group and the levodopa group were the same. And the outcome measures were very similar. We used the Bayley-3 and Mullen scale, the Vineland scale, and an aberrant behavior checklist, an evaluation for the incidence of tremors. There was really no difference in any of those outcome measures. 21 of the patients had tremors at the inception of the study. There was no change in tremors. and no change in the estimation of attention span, aggression, or other aberrant behaviors. And what was found from this study was that that dose of levodopa was well tolerated, but there was no clear beneficial response to levodopa therapy. And at the time this study was underway and starting to recruit it, a lot of people heard about it and got their clinicians to write for levodopa prescriptions for it. The next trial that came from the earlier phases of assessing this was a minocycline pilot trial done from Dr. Weber's group in Florida. And this was an open-label trial using minocycline, and the basis for that was that minocycline also was found to enhance the animal model of learning called long-term potentiation in a mouse model of Angelman syndrome. So minocycline was trialed. It was all done at a single site. Everybody knew they were getting the compound. And what happened was that they treated them for 8 weeks with minocycline and then 8 weeks off of minocycline and altered the sequence. A primary outcome measure was a change in the raw score of the Bayley scale, and secondary outcome measures were the Vineland preschool language scale, looking at an EEG score, and the CGI, the global impression of improvement. The findings of this, there was a statistically significant increase in the raw scores of communication subtest, fine motor on the Bayley, and a statistically increase in the Vineland Adaptive Behavior Scale of receptive communication at week 8, but I don't believe that held true further out. The preschool language scale of auditory comprehension and total language at 16 weeks showed an increase in the raw score, and there was no change in EEG scores or the CGI score. The conclusion of that was that future controlled studies should be done and before we can recommend minocycline therapy for individuals with Angelman. And then several years later, a group in Spain decided to do a placebo-controlled trial. And they used a dose of minocycline of 3 milligrams per kilogram up to 200 per day as a maximum. And their design was such that you either got minocycline throughout the entire 16 weeks, or you were in a group that got placebo first for 8 weeks, then minocycline, or minocycline first for 8 weeks, and then 8 weeks of placebo. This was also done at a single site. There were 32 individuals at a broad age range from 6 to 30 years of age, and they were all matched clinically in the different groups. Most of those were deletion-positive patients. The measure they used was Merrill-Palmer scale of developmental index at the baseline, 8 weeks, and 8 weeks after the end of the treatment phase, and also a CGI at 8, 16, and 24 weeks, and a qualitative EEG analysis before and at the end of the trial. And the outcome of this was that there was no difference in the developmental index at 8 weeks, 16 weeks, 24 weeks, but at 8 weeks there was a higher CGI improvement in all of the groups, regardless of whether you were half placebo at the beginning or halfway through, or whether you were on minocycline. And the conclusions of those investigators that the results did not warrant the use of minocycline therapy. And I'm not going to discuss the gabaxidol trial because I think that was done next. So with that, I'll turn things over to Elizabeth. Oh, no, to Jessica. So.
So I'm going to kind of try to change gears here and talk about common things that we see now in clinic, and just common things that are not going to really be covered in some of the other talks, but I'm staying away a little bit from talks that are going to be focused. For example, Dr. Thibert and Dr. Nespeca are going to talk about seizures. So I'm going to focus on just the diagnosis and where do you go from getting a diagnosis, which is something that I think we don't address enough. And I see a lot of people in the audience who have green first-time attendees. So I think it's really important for us to address what do you do when you get a diagnosis, which is a shock for everybody. And then talk a little bit about early intervention. And one of our goals is really to get information out there so all individuals with Angelman can get the same level of therapy, and trying to collect standards of care so that that can happen. I'm going to talk about gastrointestinal concerns a little bit, and then talk about managing puberty and beyond. So in terms of diagnosis, so I'm sure all of you remember this, and I've heard many stories from you. And so I encourage you not to Google anything and just take some time for yourselves. And you really want to focus on your own self-care when you get a shocking information like that. Take some time to really absorb it. And then you want to, your natural instinct is to want to do everything you possibly can. And so try to use that productively. So come up with a plan. And one of the most important things I can't emphasize enough is to identify your tribe. So I think all of you identify with each other in the room as your tribe, but also your support system. You need to make plans so that you're not the only caretaker for your child. So thinking about what family members can you lean on and what support can you have is really important. And you just try to use that information and be as practical as possible about how do I use this difficult time and anxiety to really put things into perspective, and what can I do right now? And then you want to take it day by day. There's so many exciting things in the future. We're all really excited about the therapies that were just talked about. But right now you have to take it day by day. And then reach out to some of the experts. So we try to make ourselves available. So all of us have email addresses, and then our clinic has an email address, and we want to hear from you all. We want to talk with you. Sometimes just talking to someone who knows a little bit about Angelman syndrome can give you a whole lot of hope and that extra strength you need to take the day by day. So I can't emphasize this piece enough. So the main thing you often can do, and the main reason a lot of individuals with Angelman syndrome are picked up, is because of developmental delay. So I can't tell you the number of kids we see in clinic that get referred, but they haven't even been referred for early interventional services. And that may be reflective of the population that we're seeing in the clinic, but there are a lot of services through the state. And even if this is not going to be all the therapy that your child takes part in, it's really important that you have that base for a couple of reasons. One is that it's an early way into early Head Start, which is great because they'll provide services through the public school system. And then, of course, private therapies, which a lot of times people do need to augment the therapies that they're receiving with private therapies. And we're going to talk about some of those. There are some strategies. I think one of the most common questions that I get is, my child has a maximum number of therapies of 30 per year. That's a joke, right? So there are sometimes things we can do, letters we can write, where they're qualifying diagnosis or things that we can at least get you past that stressful piece so that we can get your child the therapy that they need. And then talking early about equipment, because from the reality of insurance companies, it can take a long time to get equipment, so planning ahead and thinking about what equipment you might need is really helpful. So one of the things that's most important is actually speech therapy. And early talking to your child is very, very important. The problem in Angelman is apraxia, so it's actually motor planning. So a lot of parents say, my child's words are in there. They really are. It's a motor planning concern. And so the more you can get them in specialized therapies, and one of the things that we've found that can be really helpful in terms of forming specific sounds is something called prompts, which is prompts for restructuring oral muscular phonetic targets. I don't know if this is going to play. It's not. But that was a video of one of the therapists doing prompt therapy. So it has to do with appealing to multiple modalities. So not just the sounds themselves, but also touch related to sound, manipulation of the mouth to help with sound. Go back to the slide. And then also pictures. So very early on, maybe it's going to work. well, pictures, so using pictures to point. So all these different types of inputs are really, really important for developing speech, particularly when it's a problem with motor planning and apraxia. So you can see that she's using pictures with the child. It's not playing all that well. And then she's creating like tactile stimulation for how the sounds are made. And then you'll see even as the movie goes on, you know, actually putting hands on the child and helping the child form the sounds. So, and then AAC devices, which there's a whole session on them, so I'm not going to go into too much detail, but we introduced that very early. So even the pictures, so when you're first starting speech therapy, it's really important, obviously, to talk to your child, and that's actually the main input for communication that your child will have early on. And then using pictures is really, really important. And then as they get older, the AAC device referral is really based on getting a referral for a specialized device. And there's different types of devices. So there's more simplistic devices, and then as your child gains more skills, going on to more complicated devices where they can form sentences. So very young children with Angelman are still in that emergent communicators phase. And so you want to start gaining operational help with using an AAC device even this young. So again, photos, pictures, working on activating buttons. So use of an iPad can be really helpful. There's single button devices like something called the Big Mac, and people are going to go into more details at the specific sessions. But these get more complicated as time goes on. And then physical therapy is really, really important early on for low muscle tone, balance, and coordination. And then orthotics are really important. So it can help with stability. So oftentimes we'll see kids in clinic who are almost walking, but their feet go out to the side like this. And so just resituating their feet with AFO so that their feet go forward, we've seen kids take some steps for the first time because our PT has come in and fit them with ones she has, showing them examples and showing the family how much impact they can have. Because when you have low muscle tone, it also helps with your support of your body weight. And then we do know that mobility changes over time. So one of the things that can be frustrating is your child might graduate from physical therapy, but in terms of treatment, we want them to stay in physical therapy. So this is where it's really important to advocate for your child to continue to get therapies, especially through the school system. And then equipment consideration. So if children are not bearing weight, particularly by 12 months, we do recommend a stander to try to help them get used to bearing weight on their feet. And then we have had really good experience with a reverse walker. So instead of the very fancy gait trainers, just getting a reverse walker where the child can hold on and walk with it behind them, it can be really supportive. So there's different types of physical therapy as well. So hippotherapy, aquatic therapy, and there's something called spider therapy, which a lot of patients are saying is very helpful, where you kind of get suspended and you bounce, and the kids with Angelman love it. Occupational therapy is also really important, and mostly not just the fine motor skills, but also sensory integration. So there are different types of orthoses, like a vest that can provide some input that can help with excessive drooling or oromotor fixation. And so there's other strategies for dealing with oromotor fixation. So chewies or things that go around the neck. Vibrating toothbrushes can be really helpful, and then if your child will eat them and is at this appropriate stage, then crunchy foods can also help with that. And then metronome therapy is something that's out there too, that has multiple different modalities of input, which can be really nice because they can be in a gym and they can remain active during the therapy, but they have input from multiple different modalities at the same time. And then, of course, this is very important, the individualized education plan, so early advocacy for your child's very important. We advocate and this has been shown to be efficacious in terms of keeping kids in a mainstream classroom, having a one-on-one available, which I think is really important. And then this is a behavioral way to deal with things like anxiety and behavior. So the more structure, the more rewarding good behavior and token system, the more routine and consistency. So same care providers in the classroom, same one-on-one aid, the more consistency you can provide there, actually that makes a bigger impact than some of the medications. So working with the school to say, this is what my child needs, and this person needs to be consistent because this is what we know about Angelman syndrome. And so we spend a lot of time, more than I'd like to, on phone calls for IEP meetings because it can be really helpful. So getting letters, asking your doctors to be on the phone can be really helpful. And then I can't emphasize enough the importance of having all this in the IEP so that you have it all in writing. So GI concerns, so early feeding concerns and low, mostly related to low muscle tone. So you want to take a lot of precautions, upright when you're feeding for reflux, and then ensure that they get enrolled in feeding therapy. We recommend everybody very early on have a feeding assessment, which can be really helpful, not only at that time, but also as you're introducing new foods, having strategies, especially if there's any sensory concerns. Early integration of a straw cup is really important for building muscle tone around the mouth. And there's different types of cups that can be really helpful. We found the honey bear cup very helpful. Weighted straws can be really helpful to encouraging the use of a straw cup. And then we've gotten kids to use straw by making pouches of really thick things like avocado and then having them, don't squeeze it for them, but have them put it to their mouth. And a lot of times they can learn, because they're motivated to get whatever's in the pouch, they can learn to use a wider straw, which can help them transition to using a straw cup. And then reflux, early recognition is really important. And then it's always, again, a behavioral intervention first and trying to find the root cause. Sometimes that can also be related to allergies, so workup for allergies. There are medications that can help. We usually start ranitidine and often go to a proton pump inhibitor if we need to. And then cyclic vomiting is something that we talked about earlier, is very important. So we have found that it could be headaches and manifestation of headaches, and then of course anxiety, and there are medications like amitriptyline that actually treat both very well. And so we've seen kids completely resolve their cyclic vomiting by going on some of those medications. And then constipation, so I can't emphasize enough, these things seem relatively minor, but then when you talk later about seizures and sleep, all these common medical concerns and Angelman actually contribute to worsening seizures and difficulty sleeping and anxiety and behavior concerns. So these are all really important, seemingly minor things, but constipation is a big concern, and we've had tremendous success treating with MCT oil. We start at a really low dose because it can cause kids reflux and diarrhea, but it works really well. And then magnesium containing things. Oftentimes we don't need to use anything else. That really does work. And it's really safe. So we have some families continue to go up on the dose if they need it and then titrate it back down, and it works really well. And then the other thing that we're not going to talk too much about in other talks, but hyperphagia, so excessive interest in food, inability to stop eating, and really not able to feel full is something that we're seeing consistently in Angelman syndrome, particularly around high carbohydrate foods. And what we're seeing is that the higher the receptive language of the child, the more likely they are to have some of these behaviors. So diet may be of benefit here, and there's going to be several talks on diet, but something to think about. And then scheduled eating and behavioral interventions here are really important. And then puberty is a big one, again, contributing to sleep problems, behavior, anxiety, seizures. We often could see these things get worse as kids get older, and it may just be related to managing something that everybody has to deal with, like puberty. So this is where I always do behavioral strategies first. So applied behavioral analysis can be really helpful here if you get the right therapist willing to work with the child. And then continuous therapies with oral contraceptives. So to try to prevent them from having dramatic changes in their hormones can be really helpful. Behavioral sleep programs in place. The earlier you get those in place, the better. And then, again, routine and schedule to try to keep them from getting anxious and overwhelmed. So the more consistency kids with Angelman have, the more repetition. So this is why therapies, continuous therapies are so important, the better off that they do. And then we're seeing kids develop non-epileptic myoclonus during this time as well. And so I'm going to leave that to Dr. Thibert and Dr. Nespeca to talk about in terms of their seizure lecture. But that's something to keep in mind. Some of these behavioral interventions can actually make those things better too. And then, of course, managing anxiety and mood with medications that are available can be really helpful. And so talking about menses a little bit more. So girls can have seizures get worse when they start their menses or when they have cycling. And so we recommend, if parents are seeing that or if they're seeing behavioral changes, to think about doing first oral contraceptives and then keep on a continuous dose for 9 weeks. And then you have to have a bleed to decrease the size of the lining of the uterus. But it's really important. And there are some things like injectables that are mostly progesterone, so we see less side effects with them in kids with Angelman, and so that's definitely something to consider. You do have to look at bone density if you're going to be on a progesterone-only medication or injection, but it's really important for managing their seizures and other things that can come up during puberty. And then a lot of times this is a hard discussion, but intrauterine devices can be great because they can prevent having periods if that's a big concern for the family. And then we've really had more success for kids who are having side effects with the progesterone only, but we always start with a combined oral contraceptive first.
Right. Okay, so I had to kind of combine 4 hours worth of talks into 15 minutes. And I think we're running a little behind, so I'll try to condense it a little further. But there's going to be talks on seizures, on sleep, on anxiety tomorrow. So this is just kind of a very big overview of kind of the way we look at these issues and the way we treat them, not really to talk about specific treatments in detail. So just to kind of review, in Angelman syndrome, the kind of the way logical/psychological, psychiatric, it's really a disorder of the brain, the nervous system. So as you know, we disturbance, we see developmental delays, we see movement disorder, anxiety, difficult behaviors, GI dysfunction, even though it doesn't sound like it's coming from the nervous system, it probably is. In our intestines and in our stomach, the tone is low, kind of like it is in the arms or legs. And so you get issues there. And then also orthopedic and ophthalmology issues, they're often due to low tone in those, in your overall muscles and your eye muscles as well. So kind of all comes from the brain originally. So just real quick, the epilepsy and Angelman syndrome is what we call a generalized epilepsy. So instead of coming from one part or a couple different parts, it's kind of a whole brain seizure disorder at once. And that really dictates what medicines we use. So there's certain medicines that can worsen these kinds of seizures. If you look at the main types, tonic-clonic, which is kind of the big shaking seizure, eyes roll back. Atonic, which are either head drops or full body drops. Absence, kind of the staring spells. Myoclonic is kind of the twitches. And then this is from a seizure survey we did, so I think the tonic seizure was, I think the myoclonic should be higher, the tonic is less. Tonic seizures and spasms are really rare. I don't even know if they kind of happen that much. But, so these are different seizure types, which we'll talk about in lots of detail tomorrow. And, whoops. There we go. So just kind of going more through epilepsy, you have these different seizure types, and one of the things that we see in kids with Angelman syndrome that we probably see more than we do in other neurogenetic disorders is called non-convulsive status epilepticus. So you might not see any increase in seizures. You might see some staring, you might see some twitching, but what it really is there's usually a trigger, not always, but it'll come after some poor sleep or an illness or both. And you kind of see this just gradual kind of decline in communication, eye contact, balance, sleep can get thrown off. And that can be due to the EEG just kind of being, even if you're not an EEG expert, you can see kind of all the spike. So the EEG is very busy, and you may not even see any seizures, but you see this kind of decline. And so that's something that we always have to think about in Angelman, because you shouldn't ever regress. If skills are leveling off or going backwards, there's probably a reason, and this is one possibility. And then we have another thing that we call non-epileptic myoclonus that we see typically in teens or sometimes preteens and in adults, where they get kind of little twitches, kind of like if you're watching this falling asleep, you kind of twitch yourself back awake. That can happen. Clonic seizures. So we see the twitching, we see the spike and wave on the EEG. In the teens and the adults, what we'll see is someone who's totally awake and alert and understands what's going on, and they're just kind of twitching. So often it's just in the hands or in the arms, and it's pretty mild, but it can spread to the whole body and become much more and really debilitating at times. It's not seizure, it's not epileptic, so it's not hurting the brain, but it's a big quality of life issue, and that's one of the trickier things that we have to treat. This isn't a perfect graph, but the one we made for the study we did, you see it some in the teens, more in the 20s and 30s. We only had 2 40-year-olds at the time, so it's not 100% of all 40-year-olds, just the 2 that we had seen had it to varying degrees, but just kind of an idea that it just kind of ramps up as people get older. And the key to all this, so this is for the seizure, this is a seizure slide, but for everything I just talked about, the key is to really treat the other stuff, really not before, but as you treat the actual symptoms. So what we see is when there's poor sleep is a big one, anxiety, constipation, reflux, failure to thrive, so little ones that just aren't getting to eat enough, they aren't getting the calories, they're losing weight. Teenage girls, when they have their menstrual cycles, if they're irregular, these can all significantly worsen seizures, anxiety, non-epileptic myoclonus. They can start an episode of non-convulsive status. So if you're not kind of focusing on this as well as the neurological stuff, it just makes it just that much more harder to treat it. You got to get everything else working right for the treatments that we have for the neurology stuff to really work well. So we always treat this stuff. And then for seizures, it's typically medications, diet therapy, and surgical options. That's just for epilepsy in general. That's kind of what we talk about is the 3 kinds of treatments. And I won't go into, these are the summary slides from one of the talks I gave before, but this is just kind of an example. I won't go into detail, but that the broad spectrum, what we call broad spectrum seizure medicines are the ones that we have to use in generalized seizures. So medicines that treat head drops and staring spells and myoclonus and all that kind of stuff. There's medicines that aren't good for those, and if you're on those, you can actually worsen seizures. We've seen kids that have come in on one of those medicines with a pretty messy EEG. We stopped the medicine and the EEG normalized. So you can really, and there's studies that have shown that those medicines can worsen seizures. So these are medicines that can be helpful in Angelman syndrome. In the trial we did, the top ones were Keppra-Onfi and Lamictal, but that was just the patients we had. It doesn't mean that these aren't as good for kids. But when we're thinking about seizure meds, question 1 is, will it treat those kind of seizures? And so you have to have a broad spectrum medicine to treat these kind of seizures. But then that's the big thing. You don't want to worsen anything. And then step 2 is thinking about the side effects. So they can be good or bad sometimes when you think about like what else medicines do. So for instance, Onfi is a medicine that can really help anxiety. It can help sleep. So if somebody is having seizures and their sleep is terrible, this might be the first one we try. Lamictal can be a mood stabilizer. Topamax can be a mood stabilizer. Topamax can be a medicine that helps headaches if we think there might be a migraine component like the cyclic vomiters. So kind of, and it also for the kids that have the hyperphagia, they just kind of eat and eat and eat and have this giant appetite, and you have to lock the cabinets. Topamax can also lower appetite. So there's, if you think about like what side effects there might be, you can, sometimes it really helps kind of guide your choice. Medicine I'll talk about tomorrow, so Depakote or valproic acid, I know it comes up a lot. But what we saw in our initial study survey we did 11 years ago, plus in clinic, is that really more often than not, we see kids that have motor regression, decline in motor skills. Sometimes it's hard. They start it early, and then they make progress, so it seems like it's okay, but as soon as we take kids off, they do better. It's not 100%. So there are people that are on Depakote that aren't having significant issues, but in our group of patients, it was about 70%, including we had teenagers that had never walked before that just started walking off of it. So if there's motor delays beyond what you expect, seizures are well controlled, there's nothing crazy orthopedic, and just you're not seeing, walking or just and what you're expecting at that age, that's always something to think about, is it the Depakote. And then, so these are some of the newer medicines, Banzel, Vimpat, Vicom. So just there's since 2010 or 11, there's a handful of more options, which is always good. We'll talk about those more tomorrow. But there's, just the big thing is now there's about twice as many medicines that can be helpful now as there were 10 years ago, which is really a positive. And then the last couple, Neurontin and gabapentin or Neurontin and Lyrica or pregabalin. Those are not broad spectrums, but we have not seen them worsen seizures in Angelman. So we've actually used them for sleep and for other non-seizure things. They don't tend to worsen seizures. They're just not great seizure medicines in Angelman. And then the medicines that have been shown to worsen Sabril or vigabatrin, it treats focal seizures and infantile spasms. Tegretol and Trileptal. Aptium's the newer version. It may not be quite as bad as these two in terms of seizures, but as far as we know right now, it's not something that we would try. So these are all medicines that could potentially worsen seizures. And then Dilanthid and phenobarbital on a day-to-day basis can worsen these kinds of seizures. But in the case of status, they can be given IV to help kind of quiet a big seizure. There'll be 2 talks on this tomorrow, so I won't go into a lot of detail, but ketogenic diet, low glycemic index treatment, dietary therapies for epilepsy. What we've seen, so dietary therapies are very effective for seizures. They tend to work even better than medicines. They're just kind of harder to do, which is why it's not the first line for everybody. What we've seen in Angelman syndrome is that they tend to work better than they do in the general epilepsy population. So we'll be talking about it tomorrow, but it's like 81 people we've done consults for, and we have 62 that we've treated. So a lot of diet therapy in Angelman, and just on top of seizure control, what we see in these kids. So basically, what you're doing is not having your blood sugar increase with food. The few carbs that you do take are ones that don't raise your blood sugar, so you have this nice and stable blood glucose, like blood sugar load, and a nice stable insulin kind of level. And not only do we see better seizures, but we also typically see better focus, less impulsivity. We see, we don't have data to prove it, but just kind of anecdotally, we've seen kids kind of do better developmentally because A, they're not seizing, and B, they're a little more focused. So this is a good option. We haven't had to use this much, luckily, because we've had good enough luck with medications and diet therapy, but there's always surgical options for epilepsy. The big one is cutting out the part of the brain that's causing the seizure. In Angelman syndrome, that's not an option because it's kind of the whole brain at once, so there's not one little spot you can take out. So if that's kind of something you read about, that's not really an option for Angelman. But vagal nerve stimulator for it's a little thing that's implanted under the skin in the chest, and it wraps around this big nerve that kind of goes from the gut up into the brain, and it gives off a pulse, and we don't know why it works really, which I know is comforting, but it has shown in more than half the people that have been on it, they've had a 50% or more decrease. So it's never really curative, but for people that are having like many seizures a day and just nothing's working, it can really kind of decrease the whole seizure burden just to make life a little easier for everybody. Non-convulsive status, and I think there's definitely some part of the way the region is set up and the genes that are deleted or inactive, but they respond really well to benzos and Valium specifically. That's not scientific, it's just trying lots of benzos and lots of kids, and this is the one that really works better than most. So we use a tapering course of diazepam. If we see that EEG that we saw before with just constant spikes, for a lot of kids that we see without Angelman, we often have to admit to the hospital, kind of do more hardcore medicines. But for our kids with Angelman, we can actually treat at home. We put them on, kind of a good dose of Valium for twice a day or 3 times a day, and then a little bit less, and taper off. And that typically works. The majority. I think we did a study of the kids that we saw, and I want to say it was like 70, 80% really responded well to that treatment. If there are other benzos can be helpful. For some reason, diazepam doesn't do it. We've used Ativan or lorazepam, Klonopin or clonazepam. If they're in the ER and we see that, before we start the course, we might load with an IV seizure medicine like a Keppra, just to kind of get a big load IV in to start the process. And then the next level after that, if just the regular meds aren't working, the Valium's not working, we'll try IV steroids or outpatient oral steroids. So prednisone or prednisolone, not like the kind of baseball player steroids where they get all jacked up, but like the ones that you use for asthma, the anti-inflammatories. And those can be super helpful. And it doesn't have to be a true non-convulsive status if it's just a ramping up of seizures and they're having 2 a day, then 6 a day, then 10 a day, then 20 a day. Sometimes that just really kind of quiets things and gives it a break, then really kind of resets the cycle and also gives you a chance to really go up on meds more. Non-epileptic myoclonus, again, the best thing to do is, they're typically triggered. And so the big scary events are triggered. They're either because people are pooping once a week, they're crazy anxious, they're sleeping 2 hours a night. Like if you can kind of get a handle on what's behind it, sometimes that's really all you need to do to fix it. It's easier said than done. Hormonal issues, after puberty kicks in with the girls, sometimes we'll see trouble around periods. And then when we do have to go to medications, it's the medications that work for myoclonic seizures, even though they're not seizures. Myoclonus is kind of responsive, whatever kind of type it is. But the benzos, so clobazam or Onfi, Klonopin, Ativan, Valium. The Keppra family, so Keppra itself, there's a newer generation of Keppra, which was levetiracetam. This one's brivaracetam or Briviact, and it tends to work as well as Keppra, but with less crankiness. So for anyone who's been on Keppra, got too cranky, had to come off, that could be an option if it was helpful. And those two together are usually helpful. CBD is something that has been promising anecdotally. It's just been kind of approved recently, and it's approved for refractory seizures, so it's been harder to kind of get for the myoclonus. But prior to the Epidiolex coming out, a lot of families had tried, the hemp oils, the other kinds of CBD, and like anything else, some families thought it really helped, and then some didn't. So it's just another kind of another option. Again, there's no. We don't have any evidence, any clear proof that it helps, but just having families say they tried it and they saw a difference, I think is a good start. And then looking at sleep, again, why are you not sleeping? So just because of the way the region works, UBE3A itself affects the circadian rhythm, so kind of the sleep cycle. There's some GABA genes that are in there that could be affecting things. So just having Angelman syndrome kind of gives you more likelihood to have bad sleep, just based on just naturally neurologically bad sleep. But sleep can also be worsened by constipation, by reflux, by anxiety. So it's kind of thinking about why is sleep bad? What's going on? Is it just purely a sleep thing, or is there other factors that could be worsening it? So I always think of that first. So that we start by treating anything else that's obvious and maybe causing issues. And then the next best approach, and there's going to be a talk tomorrow, our nurse practitioner is giving, we do sleep training. So, as kids get older, they need less sleep, and sometimes, their sleep schedule kind of stays the same. So when we're seeing kids who are maybe 10 and they're, going to bed at 7, getting up at 7, but waking in the middle of the night, it's because kids who are 10 don't need 12 hours. They need, 9 hours, 10 hours, sometimes 8 hours. So if kids are in bed too long and they're waking up in the middle, we try to consolidate that. So we say, okay, this is how much sleep you need, so let's start pushing bedtime back. Or if they're napping during the day and they're kind of too old for the nap, like older than 4 or 5, kind of eliminating the nap, just because some kids will get say they need 10 hours a day, they might get 2 hours of nap time and then 3 hours of sleep, and then they're awake, then 2 hours of sleep and they're awake, then 3 more. So the idea is to get all those hours in a row at night when everyone else wants to sleep too. So there's a lot we can do just with sleep training. So we look for the other factors that are causing problems. We do sleep training, and in a lot of cases that's enough and that works. When it's not, we have medicines. So there really haven't been any good studies looking at sleep medicines in Angelman, but just anecdotally, there actually have been a couple of older studies looking at melatonin. It's very safe. It's an easy kind of first medicine. Works a pretty decent amount of the time. And then you have melatonin and clonidine, which are medicines that can really kind of help you fall asleep. Clonidine can also sometimes help you stay asleep. Trazodone, Neurontin, those are medicines that are even better at helping you stay asleep. They're longer acting. They can kind of last throughout the night. Other benzos, they're not great for doing it every day because eventually the effectiveness wears off. But if it's kind of as needed, you know something's coming up, there's going to be a trip, it's going to be a rough night, you can try a Valium or Klonopin just to get through those few nights. And then for ones that don't respond to any of this, we have a sleep specialist that helps us, and there's the more traditional sleep medicines like Ambien or Seroquel, but that's a small amount of kids that don't respond to the typical stuff. And then last slide, so anxiety. So Dr. Curie is going to be talking about this tomorrow. We've been doing a lot more work with anxiety. He's been studying it. And so again, the main thing, we start with behavior therapies, identifying triggers and modifying those. So, okay, you're anxious when this happens or this happens, trying to restructure the day. There's like visual schedules. There's kind of knowing what's coming next. So, there's no big surprises. They don't like those. And then again, any kind of medical issue, you're going to be more anxious if you're having reflux, if you're not sleeping, if you're all that kind of stuff. And then if needed, there's drugs. Dr. Curie and the group at MGH, put out a little case series about a few kids that responded really well to Buspar. That tends to be helpful medicine. And then I already mentioned clonidine for sleep, but for kids that are anxious but really more impulsive and bouncing off the walls, guanfacine or clonidine, so that kind of category of medicine. Remeron or Mirtazapine is a medicine that has some side effects that can be beneficial. So it's an anti-anxiety medicine, but it makes you sleepy and it makes your appetite go up. So that's a problem for some people, but for kids with Angelman that don't sleep and they're really skinny, it can be really a positive thing. And then just other anxiety medicines. The OV101 trial has been mentioned. So that's kind of just a basic. There'll be lectures on all of these tomorrow in more detail. But that's kind of an overview of just kind of how we look at it. It's always what are the triggers, what else is going on that could be worsening it, what are some behavioral type interventions, and then what medicines if we have to get to that point. And that's kind of how we look at the neurological stuff. And I think that's it for my part.
Okay. Hi, everybody. I am getting to talk after the session is already over, so I'm going to try to blow through these slides pretty quickly, but I just want to give you an idea of some of the differences between, you're all going to be exposed to clinical trials and natural history studies in the next few years, and I think we're just going to try to talk about the differences between participation in that and coming to clinic. So what the last two speakers have talked about is, wait, I've got too many things here. Have talked about is really supportive care, and we use supportive treatment. They're usually generally not proven to work in a rare disease, but we use the best practice medical care based on extrapolation from other more common disorders with overlapping symptoms. When we try to actually reverse the disease, this is how we may do better than supportive care, but this is a relatively new concept in neurodevelopmental disorders, and it has to be proven for each rare disease. So in order to prove that any of these treatments that are targeted to the actual underlying disease work, we have to be able to do clinical trials. And of course, we have to do clinical trials to prove any intervention, therapy, or medication works, but the trials that we're going to see in the upcoming years are more targeted to disease-targeted treatments. So for trials, we need a comparator, and there are several ways of having a comparator. You can have a waitlist control where some people wait to get in the trial, and then you compare what they did while they were waiting to the person who was treated right away. There are placebo controls where you take basically a sugar pill, and then you compare that to having the actual drug, and this is how most studies for FDA approval are done. Or you can have a natural history control, and this may be a kind of situation that's actually very relevant to Angelman syndrome, because this is commonly used when the intervention cannot impact the disease in a period of time that we can actually use the placebo. We need to observe the patient for longer than a year, or the results are so dramatic in an early phase trial compared to natural history that it's determined that a placebo group would be unethical. So translating these mechanism-targeted treatments in developmental disorders has been fairly straightforward, to go from genes and proteins to cells to animal models, and then there's basically been a chasm in terms of getting these treatments to humans. And so this is the space that I've been working in for the past 18 years, and in several different disorders. And I think we've had some lessons in those disorders that hopefully will apply to Angelman syndrome, and that we'll be able to avoid some of the pitfalls that have occurred in some of these other trials. So proving the efficacy of one of these targeted interventions in a rare disease is really challenging. And we made a lot of mistakes in the Fragile X field, and so we like this quote from Albert Einstein. This is, again, a new field, and even when you have a huge amount of data, as the Fragile X field has seen in basic science papers, sometimes you just can't get that drug to approval in humans. And this is because why? Because mouse is not man, animal models don't always predict human responses, the timing of developmental windows in brain may be entirely different, we really don't know. But basically, humans haven't even gone to preschool before the mouse dies. So there may be very significant differences in the sequence of timing of brain development. Size matters. I don't have a pointer, but the mouse is that little tiny dot up there, and the human brain is shown there. There's a huge difference in brain size, and that can be really important for how drugs get into the brain. Diversity and variability in man. The mouse in a lab is pretty similar to all the other mice compared to humans, and so we have a lot of variability we have to deal with, and we have to deal with the issue that only a percentage of patients may be responders, and we can't really compensate by increasing the study size like they do in depression because it's a rare disease and we can't find that many patients. And also we need biomarkers of target engagement to help us predict what would be the responders. And at the bottom there's an example of an ERP that we're using in Fragile X to try to show who responds to a given drug, and then that might help us with who the best people to enroll in a trial are. Another problem is that outcome measures have been very frustrating in conditions with intellectual disabilities because the established ones don't work well and gold standards don't exist. So we've been remapping some of these outcome measures so that they show, oops, wait, this is this, all right. So that they show a better range for developmental disabilities. We've been using more kind of play type outcome measures where we can code social interaction, and developing disease specific measures is really very important. There's a lot of problem with placebo effects. Caregiver reported measures. Everyone thinks that a medicine that we're trying in a trial is going to work, and so there's a lot of variability. There's bias toward rating just the few days before the rating, which we're trying to overcome right now in the Fragile X field with a behavioral app to avoid, so that people can actually record things in real time. Sometimes families game entry and overrate the patient so that they can get into a trial, and social media can be a blessing and a problem because if people are posting stuff about their response in a trial all over social media, then that tends to affect placebo responses. The other problem is that it can sometimes take a long time to see a result on a developmental or learning parameter like cognitive or language effects, and so we need models for natural history comparators. And this is just an example of over the first picture is an example of how we treated the mouse for a huge part of its history, and then we treated humans with Fragile X for 3 months after they were adults, and then we thought that we had done an adequate trial. And so that's something that has to change. We need to have these long trials where we can really see some of the disease-based outcomes. We may need to do registration trials in younger children who are more plastic and can change faster, and we may need to embed learning interventions to try to accelerate learning and decrease the time we need to see an effect. And if we had a biomarker that would tell us we were going to have clinical success with longer treatment, that would really be, the gold standard, but we haven't seen that in any developmental disorder that I know of yet. And that would be an example of this marker we have in the blue of normalizing this ERP with a drug, and then if it would predict an improvement in clinical function, that would be excellent, but we haven't proven that kind of thing yet. The FDA is still working to understand what is needed for each rare disease. They are as lost as we are in terms of how to best demonstrate efficacy. And to overcome these hurdles, the answer, well, we think the first piece of the answer anyway, is to have a clinic consortium that's going to collect good natural history data, provide sites with expertise in key disease-related outcome measures because they'll all be trained on them for the natural history study, and then assessments, and then expertise in working with the actual patients so that they can get the patients to do things. This network will then provide trial sites and provide expertise from the trial sites to take to the FDA with the pharmaceutical companies to work on what the most important outcomes are in Angelman syndrome. So why should you be in a clinical trial after I've told you these trials are fraught with so many problems? Well, I think we're getting better at this, and so the most obvious reason is to contribute to research, and All right, is to contribute to research and help develop new treatments that may better quality of life for those with Angelman syndrome. It may help the actual patient in the trial if it's an intervention trial, but you need to remember when you go into a trial that this is not an established treatment until it's actually proven, and we don't know if it's going to work until we use it in the trial and in clinic. An advantage of being in trials and in natural history studies is that you get frequent follow-up, you get connection to experts and work in the field, and people can answer your questions. Often you can use the assessments from a trial or a natural history study at the baseline visit, or even in a natural history study multiple visits, to use for school and medical evaluations, and you get all that done through the study and you don't have to get it privately. But it is important to avoid things that can cause a treatment trial to fail, and we do have an example of one trial in Fragile X that probably failed because of some of these things. Embellishing the severity of your ratings of how much behavior or how much problem the patient has to get into a trial is a problem. Posting side effects or benefits on social media is not a good thing. It leads to abnormal expectations and placebo effects. Assuming that you will benefit when you go in and do your ratings is another problem. You want to assume that you might benefit or you might not, and you really want to try to give an honest rating on everything. And then really, trials are a family clinical research or partnership in rare diseases to really try to maintain an objective attitude and assess things just as they are, as accurately as possible, without assuming things will go one way or the other. And the family needs to do all the things asked according to the protocol, and the clinical team needs to try to make things as comfortable as possible for the Angelman syndrome individual and family. And I think the hope is that with all of this large number of upcoming trials that we're going to see in the next 2 or 3 years in Angelman syndrome, that all of our clinics are going to be in a position to basically do this, and the families are going to be ready to participate in a way that we won't have some of the failures we've seen in other fields. And that's all I'm going to say, because I know we're way over time. But happy to take questions, and I'm sure anyone in the panel is happy to take questions.
Yes. I see one. So this is about myoclonus and about CBD. So in this anecdotal information about CBD, are the individuals also taking other medications, like, you know, our daughter is taking Keppra, she's actually taking carbidopa-levodopa, which gives us, it seems, a small reduction in tremors, but we haven't conquered it. And it is a huge quality of life issue. Currently, our neurologist is not interested in looking into CBD, but is that something that could be used on top of everything else? Is there a worry about drug interactions or?
Good question. We don't have our fancy microphone. No, so yeah, you know, the Epidiolex, the FDA-approved version, what we're seeing is that it can increase levels of clobazam, what wasn't in the trials is we're seeing it increases other medicines like Vimpat, there's a few others, but so it's not a problem to add CBD to other meds, you just have to kind of know what the interactions are and adjust the other ones accordingly. And we see less of an issue with the hemp oils, we haven't seen a big downside to trying the hemp oils on top of everything else. We've had some families that have called us and said, you know, we tried it, it's life-changing, it fixed everything. Some that said we tried it and it did nothing. And so it's kind of like any other treatment. It helps some, it doesn't help everybody, but it's one more option in the, you know, you have like a little kind of arsenal of treatments, and like anytime you can add one into the mix, it's just one more thing you can try, and the more options we have, the better chance that one's going to work. So it's not, CBD hasn't been magical like some people were hoping it was with when the Gervais folks started using it, but it is definitely an option, and it can work as well as the other meds. So you definitely talk to your, I guess your neurologist is not interested, but just anecdotally from our standpoint, we haven't seen any problems with families adding it in. Just got to kind of, use, like just use the directions. So the two most common side effects are sedation and loose stool, but most kids with Angelman are kind of under sedated and have hard stool, so it's sometimes the side effects are a bonus. But if there is sedation, the first question is it because it's increasing levels of another medication, and so some people we've had them on the Epidiolex or some other compound, they've gotten tired, then we've cut back. The clobazam or the Vimpat or something, the sedation went away. But it's possible, it's not super common, but it's possible that the CBD can just be a little bit sedating in and of itself. So it's just kind of playing around with the dosing. But it's one of those that, it's not guaranteed to work, but it has helped some families.
I know we've gone over our session time, so if you have any other dying questions. Okay, let's give it up for our awesome panel here. Thank you so much.